Hello. Hello, I'm Dr. Arvind, critical care consultant in Arlova Apollo Hospital. Today, I'm going to tell about the enteric fever presentation to ICU. Enteric fever presentation in ICU and management of the patient presented with complications of enteric fever. So, I will go to the presentation. Then first thing is we'll go to introduction. Typhoid fever was named because of symptoms and sign resemblance with typhus. Uh, Typhoid fever is actually resembled with typhus, strep typhus. So the confusion between two was resolved by the book William Jenner's on the identity or non-identity of the typhoid and typhus fevers. So after that, go for epidemiology. So typhoid and paratyphoid fevers are endemic in Indian subcontinent, and that is less than 100 per 1 lakh population per annum, and medium incidence 10 to 100 per annum in Asia, Africa, and Central South America. So the ratio of Salmonella typhi and Salmonella paratyphi ratio of disease caused by those is 10 is to 1 10 is to 1 ratio. And coming to the classification of Salmonella, it is broadly divided into invasive and non-invasive Salmonella infections. Invasive Salmonella, invasive typhoid infections caused by Salmonella typhi and paratyphi A. This is actually exclusive disease to the humans, and it will not affect the other vertebrate animals and others. And diarrhea is really plays a major role here. And non-invasive is here non-typhoid salmonella or NTS. This is a host is including humans and many vertebrate animals, immunocompromised individuals, secondary to malaria, malnutrition, and HIV pandemic. So transmission is usually a fecal-oral route and common in overcrowded conditions, refugee camps, poor human sanitation, raw fruit and vegetable contaminated with Salmonella typhi. And here pathogens is coming to the pathogens is Salmonella typhi is uh, infect to the humans by fecal-oral route by ingestion of Salmonella typhi contaminated food and food products, and it will affect the GIT, and after that it will enter there from GIT to the blood and mesenteric lymph nodes, and it will enter the reticular endothelial cells, liver, spleen, and gallbladder, from where it re-enters into the GIT tract, and there the complications appear. The Peyer's patches will hyperproliferate and necrosis and lead to the perforation of the uh, bowel, and also gallbladder. It can cause acute cholecystitis, and blood it can cause systemic infection. So the detailed pathogens is here. Salmonella typhi, first it will affect the M cells of the intestine. Here it will be engulfed by the macrophages, where inside the macrophages Salmonella typhi will proliferate, and it will proliferate, and it will uh, rupture from the Salmonella typhi will rupture from the macrophages, and it will enter the mesenteric lymph nodes there, and through the blood it will enter into the spleen, liver, and from the liver and gallbladder it will enter into the again into the GI tract. Salmonella typhi re-enters the GI tract, where it attacks the Peyer's patches again. First, it enters the Salmonella typhi enters the M cells of the Peyer's patches, the first exposure of the Peyer's patches of Salmonella typhi. After that, it re-enters from the gallbladder, and here it affects the Peyer's patches again, and the necrosis of the Peyer's patches can occur. And here there can be a complication of intestinal hemorrhage and also bleeding. And this is the broad pathogenesis of the Salmonella typhi. And clinical manifestations: the incubation period of typhoid fever ranges from 5 to 14 days. It varies with the infecting dose. The infecting dose is around 10.7 organisms per dose, and in paratyphoid, the fever, it ranges from 1 to 10 days. The duration of illness is generally classified as 4 weeks. Average severity is usually 4 weeks. First, clinical manifestations can be broadly divided into three things: first week, second week, and 3 to 4 weeks. So, first week, non-specific features mostly headache, malaise, remittent fever, means the fever is continuous, it is not touching in the baseline, that is called remittent fever, and constipation, uh, mild non-productive cough that can be seen in the first week of illness. And after this, during the second week, this second week, patient will be look more toxic, apathic, high grade temperature. Here rose spots will appear in the second to third week. Splenomegaly, abdominal pain, and diarrhea can happen in the second week. In the first week also, there is a possibility of diarrhea can happen in the first week also. And the third thing is, 3 to 4 weeks, third to 4 weeks, patient become more delirious, abdominal distension will be more, and the patient will be present with gastric distension and paralytic ileus, diarrhea more supervenes, and liquid foul green yellow stools can be happen. Patient can be going into septic shock, hypotension, toxemia, and myocarditis, intestinal hemorrhage, and perforation. The 3 to 4 weeks is called complications weeks of the typhoid. So rose spots. Actually, these rose spots are actually, these are 2 to 4 mm papules, and these are actually common on the upper abdomen, upper chest, and chest and thorax. And these are salmon-colored blanches on the pressure, appears in 2 to 4 weeks. It is usually seen in the untreated disease, but usually we are over treating the typhoid in rural areas and all. So here rose spots are actually less common to see in these present days. So rose spots is the actually this is the hallmark of the disease typhoid. Untreated, the mortality is historically described as approximately 20%, but with use of antibiotics, the death is less than 1%. Diarrhea may occur even in the first week also. Young children may be presented with high fever with febrile convulsions. Sometimes chronic and recurrent fever can also happen in association with schistosomiasis, because the Salmonella typhi can be attached to the tegument of the schistosomiasis, and it will be protected from the body defenses. So here there is a chronic recurrent fever can be happen with schistosomiasis co-infection. Relapse. Relapse can be seen in the typhoid fever, and typically occurs after stopping after a week after stopping therapy. Here, the blood culture again can become positive, and rose spots may still appear. The relapse is generally milder and shorter than the initial illness. The incidence of relapse can be will be low with the fluoroquinolones and cephalosporins when compared to other antibiotics. Rarely, second and even third relapse can also occur. And complications. Complications like intestinal, extra-intestinal complications, intestinal hemorrhage. You can classify these complications into intestinal, extra-intestinal. Intestinal hemorrhage and perforation, these are the most important complications during the second and third week. Mild jaundice, hepatitis, cholangitis, and cholecystitis, these are the intestinal complications. Extra-intestinal complications, in the CVS, toxic myocarditis and endocarditis can happen. CNS, there is a delirium, convulsions, meningism, and encephalomyelitis, demyelinated leukoencephalopathy, and transverse myelitis. These are the extra extra-intestinal complications. And when coming to other extra-intestinal complications like hematological and renal, disseminated intravascular coagulation, consumptive coagulopathy, that is consumptive coagulopathy, and hemolytic uremic syndrome (HUS), and hemolysis, acute kidney injury, and also immune complex glomerular nephritis, nephrotic syndrome. These are hematological and renal. And musculoskeletal complications like metastatic localization of involvement of the bones, joints, meninges, endocardium, spleen, and ovary. All can all can be affected. Polymyositis and septic arthritis, typhoid osteomyelitis also is more common. Is also common. And respiratory, when coming to respiratory, ARDS and pneumonia is also common. So, what are the laboratory findings? First, mild leukocytosis develop initially. With the disease progression, leukopenia and neutropenia is common to appear. And other things are low-grade normocytic anemia, mild thrombocytopenia, modestly elevated serum transaminases, and mild proteinuria are common. The diagnosis, definite diagnosis for the enteric fever requires isolation of organisms from the blood and bone marrow. The important thing here is isolation from the stool or urine. It provides a evidence, presumptive evidence, strong evidence. It is not a definite diagnosis. It is a strong presumptive evidence in the suspected case of typhoid. So the definitive diagnosis is here blood and bone marrow cultures. The blood and bone marrow culture, the difference between blood and bone marrow culture here is with the use of antibiotics, the blood culture may become earliest use of antibiotic, the blood culture may become that somewhat negative, but bone marrow culture, the use of antibiotics also there is tend to be more positive. So bone marrow culture is more specific and specific for the typhoid. So sometimes 60% of the cultures from the rose spots also positive, 60%. And here the duration of disease, specific duration of disease, first week, second week, and third week. During first week, blood cultures will become positive 90% of the cases, and second week, blood cultures will dip down to 75%, and feces culture and Widal test. These are 50% low titer Widal test. And third week, the blood culture will become positive 60% of the patients only. Here the thing is Widal test. Widal test blood culture should be done in the first week of illness because the positivity rate is 90%. And during the second week, here the important thing here is Widal test should be done in the second week because we are targeting the antibodies during the second week of illness. So we are testing for antibodies. During the first week, antibodies will not appear in the blood. So Widal test should be done in the second week, and it should be paid sera, means first we have to do in the second week of illness first test, and second test after 7 to 10 days you have to repeat the test, Widal test. We have to repeat the test. If it is a fourfold rise in the more than fourfold rise in the antibody sera, then that test will be significant and it indicates uh, enteric fever. Single test is not that much helpful. Okay, I will explain the further slides. And blood cultures in typhoid fever, first week is a 90% positivity, second week 75% positivity, third week and fourth week is 60% and 25% positivity. So blood cultures in the typhoid fevers are also as the disease prolongs, the culture positivity also become less. And how do you microbiologically you will diagnose the typhoid? This means SS agar, Salmonella Shigella agar, non-lactose fermenter, pale colonies and H2S production. The black colonies are H2S production. So this indicates Salmonella typhi, and it is a gram-negative bacilli. And coming to the most important, most common, we are following Widal test is Widal test. So this is actually Widal test. This is sensitive, is more sensitive, 46% to 94%. This is more sensitive. So the sensitivity rate is actually is very much varying from 46 to 94%. It is a tube agglutination test. Widal test can be done in slide also, but tube agglutination test uh, we will more concentrate on tube agglutination test. It should be done in second week of illness. The important thing here is first week it is negative test. Titers will rise in second week. Single test is not diagnostic. Only the paid sera samples with rising titers more than fourfold. First test should be done in the second week, and the second test should be repeated in the after 7 to 10 days. Widal test here, tube and slide agglutination test detects anti-O and anti-H antibodies in the serum of the patient. It will diagnose for, it is used for typhoid and paratyphoid fevers. And carriers of typhoid bacilli will produce an antibody against VI antigenous salmonella typhi. So for this reason, you have to see for VI agglutination for the detection of carriers. Widal test, the antigens which are used in the laboratory, O antigen, H antigen, O antigen, Salmonella typhi, paratyphi, and paratyphi B. These three are O antigen. These will share a common antigen, 12 antigen. So we'll use the O antigen only, specifically only one antigen will be used, but H antigen is different. This based on this H antigen, based on this H antigen, we will differentiate between Salmonella typhi and paratyphi A and B. So Widal test. This here two things are there: agglutination, O agglutination, H agglutination. O agglutination, we're using O antigen and antigen. So here agglutination is different. We are using O agglutination in the Felix tube, round bottom, compact and granular agglutination, and dry tube, conical bottom, H agglutination, loose cotton woolly clumps. So these are the differentiating features between the O antigen, H antigen agglutination. Here we can observe this. You can observe the different test tubes will be there in the test. Here the dilutions will be 1 by 20, 1 by 40, 1 by 80, 1 by 160, and so on. So the lowest dilution, we have to dilute the sera. We have diluted the sera with the test tubes in these dilutions. And if you want to give the test O, for example, O antigen, the test should be 1 by 160. What it mean be? Here you can see here there is a red clumping in the bottom of the test tube is observed in all the test tubes except in the 1 by 320. This is the first test tube. You didn't see any lower sediment. So here the O, if you're testing for O agglutination, the test tube where the last seen agglutination, that will be the result. Here 1 by 160 is the result of the test O agglutination. See, here is the 1 by 160. And important thing here is a titer of 1 by 80 for O antigen and 1 by 160 more than 1 by 160 for H antigen suggests enteric fever. And antibodies against H and O antigens usually have in 7 to 10 days. So that's why during the first week we didn't do Widal test. It will increase steadily up to 3 to 5th week and then declines gradually. And demonstration of fourfold is useful in the interpretation of the Widal test. Limitation. What is the limitation of the Widal test? The Widal test is limited. It is a time-consuming thing, and it is more sensitive. The sensitivity pattern is very much is more false positive, false negative. And what is the Prosen effect? This is also one of the limiting factor. Uh, it is observed when the concentration of the antibodies in the patient's sera is very much high. So there are not enough antigens in the sera are there to form a clumps. So it should. So you have to. That's why you have to dilute the sera for lowest thing, so that there will be an antibody agglutination can occur. The lack of agglutination in the Prosen is due to antibody access. So this is one of the limiting factor. And here false positive and false negative examples is also there. Cross reaction to false positive, cross reaction to non-typhoid salmonella, chronic salmonellosis associated with cystosomal infection, vaccination with typhoid vaccine, typhus, acute falciparum malaria, dengue, chronic liver disease, rheumatoid arthritis. These are all the false positive. False negative viral tests, early antimicrobial treatment following typhoid relapse, severe hypoproteinemia, carrier status. These are the false negative viral tests. And other diagnostics are typhoid and tubex. This will detect directly IgM, IgG antibodies of Salmonella typhi, and this can be in the recent times this can be adapted as a simple dipstick technique also, newer diagnostic method. And management of typhoid fever, that management, first adequate hand washing while handling the patient, and also safe disposal of feces and urine, and correction of the patient fluid and electrolyte imbalances. Antibiotic should be begin empirically as early as possible. Patient should also be monitored for complications. The important complications here is the important abdominal intestinal complications, perforation, and also bleeding. You have to see the signs of perforation and also bleeding. You have to examine the abdomen serially. So you have to keep in this these two conditions. Hemorrhage, there is a sudden tachycardia. Patient will be drowsy, more drowsy, and blood pressure will be hypertension will be seen, and this is the hemorrhage. And also for abdominal perforation. You have to see examine you have to examine the serially, you have to examine the abdomen for any decision, and also you have to check the x-ray abdomen. uh, if you have a doubt, you have to see you have to observe for gas under the diaphragm, and also other things. So the management depends mainly on the continents. If it is not required in Asia, outside Asia, inside Asia, outside Asia, there is less likely that fluoroquinolones resistance is seen. So ciprofloxacin, levofloxacin will be used 400 12th hourly, and levofloxacin 750 24 once a day. Treat for 7 to 10 days. And this is and management resistant infection acquired in the India and Pakistan or Asia. Fluoroquinolone is always mainstay of therapy for the susceptible strains. How will you see the fluoroquinolone resistance? We will test for nalidic acid resistance. If it is resistant, the organism is resistant for nalidic acid, the fluoroquinolone, it is mostly resistant for fluoroquinolones. Then you have to see for alternative is azithromycin or ceftriaxone for the empiric therapy. Avoid empiric treatment with fluoroquinolones because of resistance, and then here, the management mainly depends on uncomplicated and complicated. Uncomplicated only GI manifestations. Azithromycin 1 gram for one dose, then for 500 24 hours for 24 hourly for 5 to 7 days, and ceftriaxone 2 gram IV once daily for 7 to 14 days. And complicated like bowel perforation, mycotic aneurysm, or shock or severe infection. Here, you have to use the antibiotic meropenem 1 to 2 grams IV TID and consider dexamethasone. If the patient is encephalopathic and also hypertension is there, you have to use the dexamethasone. The dose is initial dose is 3 milligram per kg body weight, followed by 1 milligram per kg 6th hourly for 48 hours. For ESBL producing strain, it is usually meropenem, and monotherapy with azithromycin is will be more predisposed to resistance. So combination with azithromycin ceftriaxone should be used in the hospitalized patients. Management relapses. Relapse can occur after the clinical improvement. Look for complications like mycotic aneurysms, osteomyelitis, septic arthritis, hematogenous pneumonia, necrosis of the bowel wall can lead to the late perforation. So, management of complications, the two most serious complications of enteric fever, intestinal hemorrhage and perforation. Here, the blood passes per rectum can be seen if the intestinal hemorrhage is there, and management of hemorrhage is usually conservative with volume expansion and transfusion. Uh, and the definite treatment is surgical intervention. But the important thing here is conservative management with nasogastric suction, antibiotic therapy, direct diagnosis, the anaerobes, enterobacteriaceae, and general supportive care will reduce the mortality to 30%. And we have to reserve the small bowel resection for the uh, multiple perforations, and early diagnosis, appropriate resuscitation are important in the management to lower the mortality. And here, other things are mycotic aneurysms. This is the somewhat rarest of complication. Mycotic aneurysms are more common in the abdominal aorta. These Salmonella typhi organism are more attached, more affinity for the aortic wall, so they will produce a thrombus, and there is a abnormal dilation of the aorta. uh, and sometimes there are symptoms like abdominal pain, chest pain will be there. This may be missed. But the important thing here is the complications. Complications, rupture and hemorrhage can lead to the uh, drastic outcomes. So treatment is reconstruction. Treatment should be first we have to stabilize the patient. We have to use the antibiotics for 3 to 4 weeks if the patient is stable. Then we have to go for surgery, and post-operatively also up to 3 months we have to continue the antibiotics. What are the antibiotics we are used here is the third generation cephalosporins, and if anything a patient is in shock, we have to use the meropenem. These are the antibiotics we will use in the following situation. And here lumbar salmonella osteomyelitis with psoas abscess. This is common in the sickle cell patient due to asplenia, CLL, collagen disease, and malignancy in alcoholism HIV patient. It is a very rare entity. Uh, the clinical features are pain in the affected bone and fever and restriction of movement and fever with leukocytosis. Here the management is antibiotic and surgical debridement. The other complications are like septic arthritis. Septic arthritis is the same management. Antibiotic management is the third generation cephalosporins, and depending on the condition, third generation cephalosporins, and surgical debridement and septic arthritis, and also psoas abscess and other complications. And vertebral osteomyelitis is also most common. There will be clinical features of more the patient will be present sometimes. Paraplegia and lumbar pain. So here also the antibiotic should be given and followed by surgical management. Thank you. Any doubts?
Arvind,
Yeah.
can you hear me?
Yes,
Yeah.
sir.
Why do we see cross reactivity between COVID and typhoid? We see a lot of COVID patients who were
Yes, sir.
diagnosed typhoid positive, and the actual treatment for COVID got delayed. And they were
Sir,
getting treated for
yes, sir.
typhoid. Any explanation for this?
Sir, actually, the Widal test is actually this
Yeah,
is
if you, I
non-specific.
don't, Arvind, I don't know if everyone can hear the conversation, I mean, my question or not. Please repeat the question so that everyone can hear and then answer.
Why there is a cross reactivity with COVID and this typhoid? This is the question. The answer here is Widal test is more sensitive test, and here the titers for O antigen, H antigen. O antigen is 1 by 80 and H antigen is 1 by 160. So this is the normal. Commonly we are using this 1 by 80 and 1 by 160, but actually this will be differed in different types of area. Uh, if you see our area, Visakhapatnam, it will be different in different areas. So we should know the correct titer before doing the test, viral test. Before doing the test, we have to know the correct titer of that area. So then we should interpret the test results. Here the important thing we are missing is 1 by 80. Everybody is doing viral test for fever, and 1 by 80 if you are getting O and 1 by 160 less, more than 1 by 160 titer, then we are giving test positive without any second thought. That is actually a wrong practice. Actually we have to know the area, and this is also these antibodies also will be more spread in the general population. So we have to know the baseline titer of that area. And I think this is the answer I can explain.
Okay. And ARDS, do we see ARDS in typhoids, or is it only because of generalized sepsis we get ARDS?
Sir, ARDS is generally uh, is due to sepsis only. Some of the cases are explained in the literature, and management of ARDS is the same as normal ARDS. And here we will this is mostly due to sepsis and septic shock and multi-organ dysfunction. That's why we will get the ARDS. Yes, sir.
And encephalopathy, mechanism of encephalopathy in typhoid?
Mechanism of encephalopathy is more of like these organisms, so Salmonella typhi, will enter into the blood-brain barrier and will cause the same. It is due to sepsis as well as the Salmonella infection. There is a case reports that Salmonella typhi can cause that meningitis also is there. So here also the antibiotic is same as general this thing monocephaloxatraxine we are using a 2 gram IV BD. This is and also same management lines we have to treat the meninges. Yes.
Yeah. Thank you.
Any doubts? Any doubts? Shall I close the note today? Or any doubts?
Yeah, I think we can close the meeting and we
Okay.
can discuss. Yeah, thank you.
Okay. Thank you.